We should be live.
Okay, well, welcome everyone to our new year. Happy New Year, happy 2022. Hope everyone is staying safe. I'd like to welcome you all constituents and viewers on YouTube. And this is our January 2022 Group Insurance Commission meeting. Before we get started, as a matter of public notice, there was an error in the agenda that we had listed. So we want to make sure everybody knows that there's just one vote today, and that is to vote on the meeting minutes. In next month's meeting, we will have that vote on plan design. So the vote is just moving 1 month. And in our original agenda, we had misplaced the timing of that vote. So want to make sure everybody does note that and appreciate the flexibility that you are showing us on our meeting agenda. So at this point, let's get started. I'd like to take a motion for our minutes that were held last year. Our December meeting.
Madam Chair.
Yes.
We need to say who's in the room first.
So yeah, a little rusty with the new year. So who do we have on our meeting today? So I'm Valerie Sullivan, Chair. We are joined by Bobby Kaplan, Vice Chair. Designee for A&F, Cassandra Roder. Designee for DOI, Rebecca Butler. We have Adam Chapdelaine, we have Toby Choate, we have Joe Gentile, we have Eileen McEnany, we have Melissa Murphy Rodriguez, we have Timothy Sullivan, Tamara Davis, Jane Edmonds, and Gerzino Gerard, also known as Jazz. So at this point, I will entertain a motion to...
So moved.
Okay, so from Commissioner Edmonds.
Second.
Second by Bobby Kaplan. So at this point, I'll turn this over to Andrew for a roll call. I vote yay.
Thank you, Madam Chair. Commissioner Kaplan. You're on mute.
Sorry about that. Aye.
Designee Roder.
Aye.
Designee Butler.
Aye.
Commissioner Chapdelaine.
Aye.
Commissioner Choate.
Aye.
Commissioner Davis.
Aye.
Commissioner Edmonds.
Aye.
Commissioner Gentile.
Yes.
Commissioner Gerard.
Aye.
Commissioner McEnany.
Aye.
Commissioner Rodriguez.
Aye.
And Commissioner Sullivan.
Yes.
Motion passes unanimously.
Okay, so at this point, I'd like to pass this over to Matt. Before I do, I just want to let everybody know that the staff has been working really hard with the most recent COVID initiatives that have been announced both publicly and through the GIC. So I want to thank everybody at the GIC who are working really hard to stay abreast of a rapidly unfolding COVID situation. And Matt, you're going to talk more about that, but I just wanted to make sure all the staff at the GIC knows how much I appreciate their hard work on helping our members with these COVID tests. So thanks. It's your meeting now, Matt.
Matt, you're on mute.
Sorry, I just lost my Zoom feed just as the meeting was started. My apologies. Thank you, Madam Chair. Thank you, members of the commission, for joining us, members of the public following along on YouTube. We have a busy agenda today. We have 4 main presentations as noted on the agenda slide here. In addition to just touching on some highlights of the Executive Director's report, we will be presenting you our recommendation for FY23 plan design changes. We will also have a very thorough out-of-pocket report presentation from Lauren Makishima, our data analytics manager. That will take, I suspect, the bulk of the time. We'll have a brief engagement update from our Deputy Executive Director, Erica Schiavelli, and our regular CFO update. So that's what the plan is for today. Next slide. So for the Executive Director's report, per usual, we've submitted to you, if you can go back for the time being, we've submitted to you the written Executive Director's report. I'll speak to the calendar in just a moment. To start off, I want to highlight a few items in the Executive Director's report, and I'll hand it over to Brock Weidenheimer, our Human Resources Director, in just a moment. But I do want to make one important acknowledgement that we had 3 teams at the Group Insurance Commission that were awarded Governor's Citation Awards. We are very, very proud of these achievements. Our audit team, our life insurance team, and our future of work implementation team. All of these citations really highlight ways in which the GIC is modernizing our operations, helping our members and our GIC coordinators become familiar with these new modern tools that we're putting in place, and really transforming the ways that we do business just as an operating model in a really truly hybrid model. So I just want to take a moment to acknowledge those achievements and thank our staff for all of their efforts on those 3 fronts. With that, I want to turn it over to Brock Weidenheimer for 2 quick items to highlight on the human resources side. Brock?
Yep, thank you, Matt, and good morning, everybody. Wanted to talk about 2 things quickly. The first was just a quick update around COVID safety protocols that we have put in place and are maintaining as an agency. We've had those in place for some time now, and then we've taken a look and added some new elements with the recent Omicron, the rapid spread of the Omicron variant. So, but we are very fortunate that we've had the technology and resources and equipment in place to allow most of our employees to work remotely throughout the pandemic. And that continues to be the case and will be for the foreseeable future. But we do need to have some employees in the office on a regular basis for some and on an occasional basis for others in order to do the work that they do. And so for those, we have taken a number of steps, and I just thought I'd quickly go over those. One important one is we have completed our move to the new space at Ashburton, and that new space allows for a lot of opportunity to socially distance because we don't have many employees in the space now. So that really works out well for us. We've also implemented a new workspace reservation system that allows employees to go, when they're going to go into the office, can go in ahead of time and pre-select a specific workspace that they'll use for the day. And they can view which workspaces have already been reserved. So that gives more opportunity for them to socially distance as well. And we will continue that reservation system once we return on our hybrid model eventually. We've obtained KN95 face masks for employees who are in the office and provided those to employees who are in regularly, and then made others available for people coming in. And we ask employees to wear face masks at all times when they're interacting with any other employees. We've also provided disinfectant and cleaning supplies and Purell hand sanitizers throughout the office, and have those available in sort of the higher use areas, and then also available in general areas for others. And then we do have regular cleaning of the offices on an ongoing basis as well. And then the team that is in the most regularly is our mailroom team, just because of the physical nature of, the mail comes into the office and needs to be, needs to be handled. So for that team, we've taken a number of additional steps right now during the Omicron variant. And one is we've reduced the number of trips that they are taking each week. to the U.S. Post Office and to the Hurley building where they need to return sometimes for mail. And we've asked them to reduce that from daily to twice a week. And from an operational perspective, Paul and the team have been able to make that work. And then finally, we continue to be in close contact with the Human Resources Division, HRD, about any other guidance that they may be providing for employees and keeping employees safe. And we are keeping employees updated and communicating throughout. So just wanted to give that quick update. And then the second one I wanted to touch on was just to announce a very well-deserved promotion for a member of the group insurance team. Recently, we created a critical new management position in our operations group to support the ongoing rollout of technology and system modernization initiatives. And after conducting a search of internal and external candidates, I'm very happy to announce that Chuck O'Brien has been selected and promoted to that new management position. Chuck's been with the Group Insurance Commission for 5 years and has played a key role already in the modernization initiatives to date. He has expertise across all of the Group Insurance Commission systems, and just in general has a great willingness to jump in wherever needed, and is a great fit for this new role. And in that role, a key focus will be making sure that our GIC staff, as well as GIC coordinators and GIC members, are fully prepared for the rollout of any new modernization system initiatives, and also ensure that we have resources and support available to answer any questions and resolve any issues that members may have. So it's a big new role. As Matt said earlier, the modernization initiatives will continue, and it's a great comfort that Chuck will be there to help make sure it all rolls out smoothly. So those are the two items I wanted to touch on, and thank you.
Thank you, Brock. Just two other items to touch on briefly in the executive director's report. One, to note the information about our upcoming public information sessions, which we launch next week. I'm happy to say that once we launched our registration efforts and outgoing communications to our members, we got 500 people register within the first 24 hours. So as you may recall, last year we had a tremendous level of participation through these virtual sessions, and we expect the same this year based on those very early results. So we're very encouraged by that. I want to thank Erica and Leslie Montero for all their work around the information sessions, and others. The last thing I just want to note under COVID-19, an update that actually we couldn't include in the written report because it was work that was ongoing right through the end of last week. As commissioners may be aware, there was federal guidance released on Monday that directed plan sponsors like the GIC to provide coverage for rapid COVID tests, at-home tests. The guidance was released on Monday and effective on Saturday. So our team was very, very hard at work. Want to acknowledge all of the efforts of the team on that. We wanted to make sure that we got the information correct on the guidance. We wanted to make sure that we worked closely with our vendors so that they were prepared to provide coverage. And then we wanted to make sure we were communicating to our members about the benefit before its effective date. So it was a significant lift over the course of this week. We worked closely with our colleagues at Mass Health and the Division of Insurance to make sure that we were, we had a consistent approach, and we were communicating consistently to health insurance consumers so that there was as minimal confusion. So that went into effect on Saturday, and that will continue to evolve over the coming weeks as we continue to implement that. So that is the executive director's report. Before I get into the calendar, I'm happy to take any questions that commissioners may have.
I don't see any. Tim has a question. Hey, Tim.
Good morning. Matt, just a quick question on the listening sessions. In the past, there has been an email link where people who might have wanted to offer some type of testimony or ask questions or make some comments had the ability to send in those comments via email. Is that the same case this year?
I will kick that question to Erica on the details there.
Yes, Commissioner, it is.
It is.
But
Okay.
the email link is gic.info@mass.gov.
Okay. Thank you.
And as we did last time, I mean, we very successfully managed a very dynamic discussion where, in addition to receiving that feedback through that mechanism, we also just have live questions that can be submitted to us that we can address in real time. Of course, we can't get to all of those, but we'll do our best to get to the ones that rise to the top as themes or things that we feel are particularly important to address.
Okay, thank you. I just wanted to make sure that people who might not have had the opportunity to be at one of those 3 sessions did have the opportunity to make comment or give information, etc.
Yeah,
thank you.
And the recording of the sessions will be available on our website for as a reference for those individuals that can't make it.
Thank you.
And are you anticipating, I guess this is a question for staff as well as commissioners who represent our constituents, do you anticipate significant questions about the upcoming procurement? What has been your thinking about preparing for the listening sessions and the content and the approach?
Yeah, maybe ask Eric to come in behind me on this one, but I would say, knowing that that is likely on the minds of our members, and the fact that we have very little to say, I think, about changes to plan design, as we'll get to a little bit later in this meeting. We did include a section that addresses the procurement and give some of the same information that we've been providing to the commission about that.
Okay, great.
But I do anticipate some questions there.
Yeah, we've attempted to kind of preempt some of those questions by giving the information right out front. But of course, always open to feedback through the gic.info@mass.gov email and through our contact form as well.
All right, unless there's further questions, I'll say just a word about the calendar for the commission. So February through April is going to be a very busy time for the commission and for the staff. We will be preparing for FY23 with the vote on plan design and rates. We will begin the procurement process for our employee assistance program, and we will be preparing for the release of the request for responses for the health benefit for fiscal 24. So here, what I'd like to do is to ask for the sort of patience, flexibility, and forbearance of my commission. We have a tremendous amount of work to do. We are committed to communicating with you as much as we can over the coming months. Again, reminding you that once the RFR is out, there is very little that we can share about progress on those efforts until we come back in the fall. And we may need to adjust the schedule, perhaps extend a meeting or two, perhaps add an additional meeting. We want to make sure that we are balancing a number of different important objectives here. We want to wrap up our engagement efforts. We want to make sure that we get the strategy details right and the language into the RFR. As I said, we want to communicate with you in addition to our members about the procurement and stick to our timelines, which is really essential. So that may require us to make some changes or adjustments to the calendar here. So I just want to ask for your forbearance as we do that. I'd say on the strategy front, you can expect, as the calendar suggests here, a presentation on strategy in February. We will share as much as we can with you based on where we are at that point. And we expect to come back before you again once more, either in March or April, with more detail before the release of the RFR. That is our plan. And then, of course, we'll be coming back to wrap up the EAP procurement, the health and pharmacy procurements, and votes on all of those by the end of the year. So we have a busy year ahead, as we all know. Thoughts or questions on the calendar before we move on?
Matt, it's
Yep.
Toby.
Toby has-
Yes, could we have a discussion sometime about what the experience has been with the EAP, and is it worth carrying it forward?
Yeah, that'll be, yes, we will.
Okay. Is that the item on next calendar for February?
Yeah, so for March, we start that process by launching the procurement for our consultant for the EAP. And then we will vote on the consultant for the EAP in June. And then again, be coming back to you, as the calendar suggests, in September and October with votes on the actual procurement. So throughout that process, we will have the opportunity to discuss with you all what the future of the EAP holds, what our recommendations are, and get your feedback.
Thank you.
I don't see any other hands up. Matt, you can continue.
All right, terrific. Let's move on to agenda item 3 then, FY23 plan design. Slide 7, great, thank you. So Jim Rust, our CFO, and I will tag team on this agenda item. As you know, actually, if you can move to the next slide. So FY23 will be the 5th and final year of our current contracts with the current procurement. And as you know, in general, we like to preserve the bulk of changes to our plan designs for the procurement process and only make minor adjustments in year-to-year plan design, something that is especially important and true in the midst of the current situation with COVID-19. So this year we are proposing no changes to copays or deductibles for our members in the active and Medicare plans. I will note, as we always note, that the federal government may make changes to the federally regulated Medicare plans, but we are not proposing changes at the GIC at this time. And we are proposing expanding our behavioral health benefit by making one small but important change. Before I say a few more words about that, actually, why don't we go to the next slide and do the plan design changes, and then we can take questions generally. So as we have said in prior meetings, behavioral health, particularly behavioral health access, is a top level strategic priority for us at the GIC. In 2019, the Commonwealth required fully insured commercial health insurance plans to expand coverage for a wide range of community and family-based mental health services for children and adolescents. So as the slide here indicates, the DOI issued a bulletin relative to mental health parity regarding these services. Some of these services, through our evaluation, are being covered today by GIC plans, but we also want to make sure that we take the step to make sure the benefits of the GIC are fully aligned with commercial coverage in the fully insured market. So what we are essentially doing is directing our carriers to do for the GIC plans what they've already done for the rest of their fully insured commercial book. So these services are largely community-based and family-based services for children with behavioral health needs. They include services such as mobile crisis intervention, family support and training, in-home therapy, community-based acute treatment, and a number of others. So with that, I will ask Jim if he just say a few words about the impact of this additional benefit on the GIC spend as we see it.
Thanks, Matt. So just very quickly, there's a slide here that shows you by plan. As we do with any plan design change, we take a look at what the impact is, both on the number of members and the cost. WTW, the actuary team there, does that for us. And the impact on this is fairly minimal in terms of the $2.3 billion budget. It comes out to approximately 1.1 million in additional cost to the GIC, spread among the plans as shown in that chart. And just for perspective, that is less than 0.1% of the anticipated FY23 budget. So all in all, as Matt said, some of the plans we're doing a lot of this. So the impact on our finances is just incremental. I'm happy to answer any questions when Matt is done wrapping this up.
All right, that concludes our presentation on the plan design, and we're happy to take any questions.
Bobby, do you have a question?
I do. So I just wanted to know about the services, the behavioral health services. So once the deductible is satisfied, are all the services totally covered? Or will there be, co-insurance?
So they would be handled in the same way that any other covered benefit would be handled as it relates to cost sharing. So the way the Division of Insurance Bulletin, and this is the way the Division of Insurance Bulletin, as I understand it, was constructed. And so if an individual has a deductible, they would be subject to cost sharing up to the deductible. When they've met their deductible, they will still be subject to copays up to the out-of-pocket max, presumably. So in that sense, they are no different from any other covered benefit that GIC offers.
Okay, but it's the same deductible, right? In other words, it's not a separate deductible.
That's correct.
Right. Okay.
Yeah.
I'm very curious how I meant to ask before about during the enrollment period, I didn't see any sessions listed on the calendar. And I was curious whether, particularly as it relates to the changes in behavioral health, if that's going to be, I guess, highlighted during those sessions, or is that going to be, left to the public information sessions?
So we will use, we'll use all of our normal communications channels for this sort of a benefit. I would say we will include them in the public information sessions. We have been also working on a separate communication that is still in the works to our members that would highlight a few benefits that people may not be aware of. So this may take the form of a postcard or some other communication, but this would be one because it's a new benefit that we want our members to be aware of. It will include also an expanded benefit on contraception. That was a change that we made to our benefit within the last 2 years, I believe, based on a statute that was passed. There's a good deal of desire to make sure that people are aware of that benefit because it's not been used to the degree that some would like to see. So I know we, the Division of Insurance, and others are taking some steps to make sure that members are aware of that benefit. So so those are the communications channels that occur to me at the moment. If there are others, I might ask Paul Murphy or Erica Schiavelli just to add anything here.
Thank you.
I mean, Matt, one thing we do is we do list what's new for benefits during open enrollment in the benefit decision guide to members. And we also communicate benefit enhancements or changes to all of the coordinators with the annual enrollment information too. So we do try to distribute as much as we can.
Great.
And typically the public information sessions are used and held at the time that they are, such that we can present recommended or proposed plan design changes to the commission, and then kind of offer them up to the public as part of our presentation during those public information sessions.
That's great. Eileen has her hand up unless there's more on Bobby's topic.
All right. Thanks, Matt. This presentation raised a question for me. It's not directly on point, but thinking about the pandemic and its impact on mental health. And then I know later on the agenda, there's a report on out-of-pocket expenses, but having glanced at it, it looks like a lot of out-of-network stuff is for substance abuse. And then Toby's question about the EAP raised for me, I guess what I consider kind of an opportunity, but first would need more information. But to the extent that the GIC is analyzing that usage and that data and thinking about ways potentially to better coordinate those programs for improved results. So it's just a thought off the top of my head, but I wanted to raise it because I think there's a lot of money and usage of all of those programs, and to the extent we can coordinate and enhance them and improve the service, but also maybe reduce cost, I think that we should further examine it.
Yeah, thank you for that, Commissioner McEnany. That's we are very much thinking along those lines. As it relates to the EAP, we want to make sure that we view the EAP and what it can offer as value to our members in the light of what benefits they have available to them for behavioral health services as well, right? We don't want them to be duplicative. We want them to be complementary, and are viewing those together as part of the same kind of longer term strategy. And I will note in the calendar that we are coming back in May for an update on behavioral health and our agenda as it's emerging in that space. And it coincides nicely with our discussions around the EAP. Was one other thing I wanted to mention there. Yeah, so one of the pieces of good news here, I think, is that our behavioral health strategy is not limited only to the health benefit procurement or even the EAP procurement. So we will not be missing a significant window to implement new behavioral health strategies when the procurement comes and goes. So this will be an ongoing discussion around our behavioral health strategy. We have a lot of work happening in the background here that we're eager to bring back to you for further discussion.
Great, thank you.
All good questions. I don't see any others, Matt, so we can keep on agenda and on time.
Okay. So with that, we will move on to our out-of-pocket report. So next slide. So here I want to hand it over. I'm excited to hand it over, frankly, to Lauren Makishima to present the annual out-of-pocket report. I want to thank Lauren and Margaret Anschutz in our data analytics unit. They've done a lot of work this year to refresh this report and add some new elements and insights into it that we're excited to share. It is important, I think, to understand how out-of-pocket spending impacts our members. Our members are, of course, not the most highly paid professionals in our economy, despite the outstanding work that they do, really important work that they do. And of course, our retirees living often on very modest pensions and fixed incomes. So understanding how this out-of-pocket obligation affects our members is really important, particularly the high out-of-pocket households. I know this is usually a very small number of our members, but I think we need to weigh that fact also against the really significant impact that the high out-of-pocket expense members experience. So with that, I'll turn it over to Lauren to guide us through this report.
Great, thanks so much, Matt. Good morning, commissioners. Can everyone hear me okay?
I can hear you great. Hi, Lauren.
Okay, wonderful. Thanks so much. So good morning, commissioners. My name is Lauren Makishima. I started at the GIC last July as the new data analytics manager working on Margaret's team. And part of my job is to manage our new MedInsight claims data warehouse and produce insights using that data. And today I'm really excited to be able to present out-of-pocket spending data to you for fiscal year 2021, which runs from July 1st, 2020 through June 30th, 2021. And I'll make sure to pause periodically to take questions. So before we dive into the data, I wanted to talk a little bit about what out-of-pocket costs are and how our plans are structured with regards to those costs. Out-of-pocket costs are medical and pharmacy costs paid by the member, including deductibles, copays, and coinsurance. Once a member's medical and pharmacy costs combined reach the out-of-pocket max, the GIC covers 100% of the cost of that member's covered services. All non-Medicare GIC plans have a $5,000 in-network out-of-pocket max for individual policies and a $10,000 in-network out-of-pocket max for family policies. For a family policy, no single member's in-network out-of-pocket costs will exceed $5,000. Most of this report will be focused on members with high out-of-pocket costs, so I'd like to walk through some of the scenarios that could cause members to incur high out-of-pocket costs and even potentially exceed the plan's out-of-pocket max amount. Broadly speaking, utilization outside of plan parameters is the main way that we see members exposed to high out-of-pocket costs. So what does utilization outside of plan parameters mean? One example would be seeking care from a provider that's out of network for non-emergency care or without pre-authorization. For limited network or HMO plans, services provided by an out-of-network provider are not covered. For plans with broad networks or PPO type plans, out-of-network providers are covered, but are subject to higher cost sharing levels and a separate out-of-network deductible and out-of-pocket max that accrue independently from the in-network deductible and out-of-pocket max. And an individual member could theoretically reach their in-network out-of-pocket max of $5,000 and then seek care out-of-network and be responsible for additional coinsurance or copays that results in the total out-of-pocket spending within the plan year exceeding $5,000. On the pharmacy side, an example of utilization outside of plan parameters would be filling a brand name drug when there is a generic equivalent available. In this scenario, the patient is responsible for the cost difference between the brand name and generic drug, in addition to the generic copay. This is called the product selection penalty, and the penalty amount does not apply to the out-of-pocket max. One important thing to understand about these penalties is that it's often unclear whether the patient is actually paying the product selection penalty or not because of the availability of manufacturer coupons, which are sometimes called copay assistance programs or discount programs. Manufacturers may offer these programs for new or high-cost brand name drugs, especially when there is competition from other manufacturers. These programs cover the entire penalty amount so that the member is actually only paying a small copay out of pocket at the pharmacy. In these instances, we usually don't get any data from the pharmacy that shows that a coupon was used, so this report assumes that the patients paid the full amount, even though that's likely not always the case. We'll take a closer look at some of these instances a little later in the report. Another example of utilization outside plan parameters would be repeatedly filling a 1-month supply of a maintenance medication at a retail pharmacy. Maintenance medications are usually for chronic conditions, for example, drugs to treat high blood pressure or cholesterol, and are typically taken on an ongoing basis. Coverage for these medications is limited to 2 30-day supply fills at a retail pharmacy. After that point, the member is expected to order a 90-day supply of their medication through home delivery. If the member continues to fill 1-month supplies at a retail pharmacy, the member will be responsible for the full cost of the medication. This is called the retail refill penalty, and it also does not count towards the out-of-pocket max. Depending on the drug, some members may use manufacturer coupons to avoid paying the retail refill penalties. Another factor at play in this scenario is members with VA benefits who can fill their prescriptions at any VA pharmacy with no cost sharing. The VA pharmacies are considered retail, so the retail refill penalty would apply, but the VA pharmacy does not actually collect the penalty, so the member is not actually liable for the penalty amount. Again, this report assumes that members paid the full penalty amount when calculating out-of-pocket costs, since we're unable to definitively determine whether coupons or other coverage were used. Finally, members are also responsible for the full cost of non-covered services or services that are not medically necessary under the plan parameters, for example, acupuncture or certain cosmetic procedures. We typically don't see this in our data since this is not processed through health plan claims. On the pharmacy side, the member is responsible for the full cost of drugs that are excluded from the formulary. Manufacturer coupons may also apply in this instance. And I'll pause here for questions before we dive into the actual data. That was a lot of information.
I think we've got a seasoned group of commissioners who pay attention all these years. So they're good, Lauren.
Excellent. All right. Thank you. Next slide, please. All right, so diving right into the data, the average out-of-pocket cost per GIC household was $1,209 in fiscal year 2021, which amounts to a 2.4% decrease from the fiscal year 2020 average. One of the main reasons for the decrease was the policy that waived cost sharing for all telehealth visits during the COVID-19 state of emergency. This order was effective between March 16, 2020 and June 30, 2021. So effectively the last quarter of the fiscal 2020 plan year and the entire fiscal 2021 plan year. A couple of quick notes about data sourcing for this report. All of the data was pulled from our new MedInsight data warehouse and includes all GIC members, Medicare and non-Medicare, unless otherwise stated. Next slide, please. So if we look at this in terms of aggregate costs for all GIC households, out-of-pocket costs decreased 2.9% to $273.4 million. During this same time period, GIC paid claims actually increased 13.9%, which we'll take a closer look at on the next slide. Next slide, please. Great. So starting from the top left, the blue line on this graph shows the aggregate GIC paid claims for the last 3 fiscal years. You'll see that paid claims decreased 5.3% between fiscal year 2019 and fiscal year 2020. This decrease was due to the sharp decline in utilization during the first few months of the COVID-19 pandemic as appointments and elective procedures were canceled. Starting in July 2020, utilization began to rebound as patients returned to doctors' offices and hospitals to receive care that had been deferred. And this rebound continued through fiscal year 2021, resulting in GIC paid claims that were 8.9% higher than in fiscal year 2019. The bars along the bottom of this graph reflect out-of-pocket costs, with deductibles in green, coinsurance in yellow, and copays in purple. And the graph to the right shows these components in greater detail. Here we can see that the main reason for the decrease over time was the decrease in copays, which were 21% below fiscal year 19 levels in fiscal year 20, and 27% below fiscal year 19 levels in fiscal year 2021. So even though utilization and paid claims increased in fiscal year 2021, member costs decreased due to the waived copays. Next slide, please. This slide shows a distribution of households by their fiscal 20 plan year out-of-pocket costs. So we've got number of households in purple with the vertical axis to the left and brackets for out-of-pocket spending levels along the horizontal axis. The yellow line with the vertical axis on the right represents the cumulative percent of total households in each bracket, or in other words, the percent of households that fall above or below that particular spending bracket. In fiscal year 20, the median out-of-pocket household spending was $979. You might remember from the first graph I showed that the average out-of-pocket spending per household was $1,239, which tells us that our average is being influenced by outlier households with high out-of-pocket spending. And we'll talk about those households in a lot of detail later in this report. Next slide, please. In fiscal year 2021, the median out-of-pocket household spending was $945, a $34 decrease from the prior year. The average out-of-pocket spending per household was $1,209. Next slide, please. In looking at how GIC benefits compare to other large plans nationally and within the industry, this data from the Willis Towers Watson 2021 Financial Benchmarks Survey shows that GIC benefits offer out-of-pocket costs that are half the benchmark average at 7% of total costs. That's the blue slice in the pie chart on the bottom right, and below the industry average, which is 9% of total costs. The bar charts show the same figures in dollars, although it's important to note that the dollars for the benchmarks are unadjusted for factors where they may differ from the GIC, like age, gender, family size, and geography.
Yeah. Hey, Lauren, Bobby has a question.
Please.
Hi, Lauren. This is great information, by the way. Really appreciate it. I have a question regarding the out-of-pocket, the services. I'm very curious what services are not covered that would cause, a family or, an individual to seek services that are not typically covered. Is it the services themselves, or is it the particular physician who may not be in network? I don't know if you have any information on that.
Sure. So I guess one distinction would be that for plans that don't have out-of-network coverage, out-of-network services, so services provided by an out-of-network provider, are not considered covered services. So for those members, we'll look a little bit more closely at where the out-of-network utilization is concentrated later in this report. But what's not reflected in this report are services that might not be considered medically necessary. So cosmetic procedures or acupuncture are some of the common examples. Vision care for adults typically does not count within that category. So for those categories that are not covered services, we don't actually receive claims for those services. So they're not typically included in this report.
Thank you.
Great. If there are no other questions, we can move to the next slide. All right. So the rest of the report is mostly going to be focused on understanding the factors that result in some households incurring $5,000 or greater in out-of-pocket costs in fiscal year 2021. Next slide, please. Great. So jumping right into the data, this chart shows the distribution of the 2,508 households that had at least $5,000 in out-of-pocket costs. The color of the bars indicates whether it was an individual policy in yellow or a family policy in purple. As a reminder, the in-network out-of-pocket max is $5,000 for individuals and $10,000 for families. The total households in this graph represent 1% of all the households that had GIC coverage in fiscal year 21. The number of households exceeding the $5,000 threshold fell 7.2% from fiscal year 2020. And we're going to take a look at this same graph in a few different ways in order to better understand this population and some of the factors at play in these out-of-pocket amounts. Next slide, please. Oh, thank you. So this is the same graph, but labeled with the average GIC paid amount for the households in each bar. For example, among the 772 households that spent between $5,000 and $5,500 out of pocket, the GIC covered an average of $106,000 in claims per household. You'll notice that the average GIC paid amount per household increases as the out-of-pocket brackets increase, doubling to over $200,000 in paid claims for the $9,500 out-of-pocket bracket, with the exception of the final bar, which shows households with $10,000 or more in out-of-pocket costs. The pharmacy penalties are an important part of this story, and we'll take a look at that bar more closely in a few slides. So the main point of this slide is to demonstrate that, as you might expect, members who end up in this category typically have intensive healthcare needs with high total costs. On average, across all households in this graph, the GIC covered 95% of the total cost of medical and pharmacy care. Next slide, please. About a third of households with $5,000 or more in fiscal year 21 out-of-pocket costs also had high out-of-pocket costs in fiscal year 20. Households with fiscal year 20 out-of-pocket costs that exceeded $10,000 are in green, and those that exceeded $5,000 are shown in yellow. These members may have chronic conditions with intensive healthcare needs. I think I see a question. I'll pause here.
Yes, thank you. I guess what I'm struggling to kind of understand is the $5,000 threshold, particularly as it applies to families, without knowing how many family members. So I guess I'm trying to understand, like, is there a scenario where you could have 6 members in a family, and so the out-of-pocket expenses at $5,000 on an individual basis is about the average?
I'm not sure if I understand the question. I think in a scenario where you have 6 members under a family policy, one individual member's costs will not exceed $5,000. So if you had only one member who utilized services out of those 6 members, their costs would not exceed $5,000, but the family policy out-of-pocket max of $10,000 applies to all members. So for example, if you had 6 members who utilized $2,000 of out-of-pocket costs each, their costs would be capped at the $10,000 total out-of-pocket max.
No, I understand that, but when you're showing the family coverage, which is the purple bar, which is most of it, right? And it's exceeding $5,000. Can that be the sum of each individual's deductible equaling $1,200?
Sure. So yeah,
okay.
The amounts reflected that put each household into each bar are reflective of the total family or the total household spending.
Yeah. I mean, that's just, so that's a different scenario, right? When, if we're looking at people with very high out-of-pocket expenses, which I think we're defining as an individual with 5,000 or more, that's very different than when you're showing a household that has out-of-pocket expenses at 5,000 or more, because the number of people in the household could mean that the per individual spending is about the average. That's why. So this information to me is somewhat an apples to oranges comparison, right?
Sure. Yeah, I think the purpose of including the family policies with over $5,000 in out-of-pocket costs is really just to acknowledge that $5,000 in out-of-pocket costs is a lot, even if you have several members in a family policy. And so we wanted to include that population in this report in order to better understand, where those out-of-pocket costs are being incurred, even though they might not have exceeded the policy's out-of-pocket max.
Well, but the only thing about that is then, I mean, we don't know the total household income either, right? So, if you have 6 people and they're all
Sure.
working, then it's a different scenario. So I think the numbers are somewhat inflated without more information. That's all.
Thank you for that feedback. We can make sure to incorporate that feedback
Sure.
into future reports. All right, if there are no other questions here, we can move on to the next slide, please. Great. So we talked at the beginning of this presentation about utilization outside of plan parameters being a driver of high out-of-pocket costs. This graph visualizes out-of-network spending by color, with purple representing 15% of medical out-of-pocket costs incurred out-of-network, and yellow representing up to 31% of medical out-of-pocket costs incurred out-of-network. On average, across all brackets, these households incurred 1/5 of their medical out-of-pocket costs from out-of-network services. This demonstrates an overlap between households with high out-of-network utilization and high out-of-pocket costs. We'll look specifically at out-of-network utilization and where those out-of-pocket costs are occurring in the next section of this report. Next slide, please. Finally, I want to talk a little about the influence of pharmacy penalties on out-of-pocket costs. The yellow represents households that would not have exceeded the out-of-pocket max threshold if pharmacy penalties were subtracted out of their out-of-pocket costs. And as a reminder, those include product selection penalties and retail refill penalties. The bar on the far right shows that over half of the households in the 10,000 plus out-of-pocket cost bracket exceeded the out-of-pocket max due to the pharmacy penalties. And this is the reason why some of the trends from the earlier graphs didn't hold when you got to this last bar, because the out-of-pocket costs were driven by pharmacy penalties and not out-of-network utilization or some of the other factors that we looked at. As a reminder, it's likely that some or possibly all of the households in yellow here were accessing manufacturer coupons or other coverage, but that doesn't appear in our data, so we're not able to say definitively. Next slide, please. Great. So a few key takeaways on households with high out-of-pocket costs. Trend-wise, the number of households with $5,000 or greater and $10,000 or greater in out-of-pocket spending decreased between fiscal year 20 and fiscal year 21. On average, the GIC covers 95% of the total medical and pharmacy costs for these households. For those with $5,000 to $10,000 in out-of-pocket costs, the GIC paid an average of $125,000 per household in claims. That figure increases to $175,000 per household in GIC paid claims for households with $10,000 or more in out-of-pocket costs. Finally, out-of-network utilization and pharmacy penalties are important drivers of high out-of-pocket costs, and we'll explore those factors in the next 2 sections of this report. Next slide, please. Great. So next we'll take a look at the types of treatment where high out-of-pocket households incurred out-of-pocket costs in order to better understand where that out-of-network utilization is concentrated. Next slide. Great. So this is similar to the aggregate total out-of-pocket graphs that we looked at the beginning of the report, but this graph is limited to medical out-of-pocket costs and split by in-network out-of-pocket costs in purple and out-of-network out-of-pocket costs in yellow. We can see that there's been a consistent proportion of costs incurred out of network, about 17% over the last few plan years. One of the main reasons why members may seek services out of network is due to a lack of in-network provider availability. Next, we'll take a look at the types of the clinical conditions that are correlated with out-of-network spending, as well as what types of out-of-network services members are using. Next slide, please. So this chart shows fiscal year 21 out-of-pocket spending by major diagnostic category for the $5,000 to $10,000 out-of-pocket households. The top 10 diagnostic categories by total out-of-pocket spend are listed in the rows, and there's one bar for medical on the left, split by in-network in purple and out-of-network in yellow, and one bar for prescription drugs on the right, split by regular cost sharing in purple, retail refill penalties in blue, and product selection penalties in green. Of all the diagnostic categories here, conditions requiring orthopedic and rheumatology treatment, such as joint degeneration and rheumatoid arthritis, accounted for the highest proportion of out-of-pocket dollars. These patients tended to have high medical costs as opposed to prescription drug costs, and spent 22% of out-of-pocket costs out of network, which is a little higher than the average of 16%. Another really important finding for this slide is the high percentage of out-of-pocket spending occurring out of network for behavioral health conditions, including psychiatry and chemical dependency. Nearly half of out-of-pocket spending for the psychiatric diagnostic category happened out of network for this high out-of-pocket cost population, and that figure increases to 71% when we look at the chemical dependency category. In recent years, the proportion of out-of-network utilization for behavioral health conditions has been consistently high as the supply of in-network provider availability of mental health and substance use disorder treatment has unfortunately not been able to meet the demand. And we'll explore this issue in detail in a couple slides. Next slide, please. Now let's take a look at where services are being received for the same high out-of-pocket cost population. This graph shows the same out-of-pocket costs, but this time with a focus on medical service categories. So focusing on the areas with high percentages of out-of-network, out-of-pocket costs reveals a pattern that matches up with the condition data that we just looked at, with 73% of inpatient alcohol and drug abuse treatment out-of-pocket costs incurred out of network, along with 89% of outpatient alcohol and drug abuse treatment out-of-pocket costs, and 55% of outpatient psychiatric professional services out-of-pocket costs. Next, we're going to take a look at the same two graphs, but for households with the highest out-of-pocket costs of $10,000 or greater. Next slide. Great. So this chart shows the same out-of-pocket breakdowns by the top 10 major diagnostic categories, but for households with at least $10,000 in out-of-pocket costs. Immediately, you'll notice that the pharmacy side of this graph is a much bigger part of the story for this population than for the population on the previous slide. Thanks to the more granular data available in our new MedInsight database, we're able to split out these pharmacy out-of-pocket costs into penalties and copays, which is especially important with regards to the penalties, since we know that some members may have used manufacturer coupons or other pharmacy coverage and may not have actually paid these amounts. We also reached out to the health plans and PBMs for case information about each household that exceeded $10,000 in out-of-pocket spending in order to better understand why they may have incurred such high costs. I'll start from the green bar at the top right, which represents product selection penalties for drugs used to treat neurological conditions. 99% of this green bar was for anticonvulsant drugs used to treat epileptic seizures. These drugs were either not on the formulary or had generic versions available. Some of the largest penalties were incurred by a handful of patients with a rare and severe form of pediatric onset epilepsy called Lennox-Gastaut syndrome. While the first-line therapy for this disease is anticonvulsant drugs, one of the challenging features of the disease is that patient responses to different anticonvulsant drugs vary widely, and patients may need to try several different drugs to find a regimen that treats their specific symptoms. Several of the drugs with the highest product selection penalties in this category do have manufacturer coupons available, and while we have no way of knowing for sure, we believe it's likely that most, if not all, of these members used coupons given the really high penalty amounts. It's worth noting that there's also an appeals process that members can use to get specific drugs covered based on the member's medical conditions. Some of the retail refill penalties in blue also stand out in this graphic. However, after reviewing some of the penalties in further detail, the retail penalties incurred under hematology, that's the $121,000, and gynecology, that's the $67,000, were actually specialty drugs filled at VA pharmacies, which means that members did not actually pay the penalties due to additional VA coverage. The last point I'll make on this slide is that although the scale here is distorted by the very large aggregate pharmacy penalty amounts, the proportion of out-of-network, out-of-pocket costs for psychiatric and chemical dependency conditions is also significant in this population at 52% and 82% respectively. Next slide, please. Again, so this graph shows the types of services that our highest out-of-pocket cost households received. We see similar patterns as with the $5,000 to $10,000 out-of-pocket household population, except the percentages of out-of-network spending are even higher, which indicates that greater out-of-network usage is a factor in incurring the highest out-of-pocket costs. One service category that particularly stands out is the 100% of out-of-network spend on outpatient alcohol and drug abuse. This percentage was 89% in the $5,000 to $10,000 out-of-pocket cost population. These are primarily intensive outpatient services or partial hospitalizations, some of which occurred at out-of-state facilities. Next, we'll zoom out and take a look at out-of-network behavioral health spending in the broader GIC population. Great. So first, let's look at what types of behavioral health diagnoses incur out-of-pocket costs. This is a graph that shows aggregate out-of-pocket spending for any claim from the GIC's full population that had a primary diagnosis in one of the behavioral health categories shown on the left-hand side. That aggregate out-of-pocket spending is then split by in-network in purple and out-of-network in yellow. We can see that the highest volume of out-of-pocket spending is for anxiety and mood disorders, with a little over a third of out-of-pocket costs being incurred out-of-network. Alcohol and substance use related disorders also stand out on this graph as conditions with high out-of-network usage at 59% and 43% of spending happening out-of-network, respectively. Although the total volume of spending is lower than anxiety and mood disorders, which reflects the lower prevalence, the percent of care being sought out of network is an ongoing challenge both within the GIC and nationally that's reflective of the lack of available in-network care. Our plan to address these challenges is to work with our health plan partners to align with the EOHHS Behavioral Health Roadmap, and I'll talk about some of the specific tenets of that roadmap during the key takeaways portion in a few slides. Next slide, please. Next, let's take a closer look at some of the spending and utilization trends in alcohol and substance use related disorder in the full population. These graphs show trends from fiscal year 2019 through fiscal year 2021 in utilization along the top row, out-of-pocket costs in the middle row, and GIC paid claims in the bottom row. The columns show where these services were rendered, with inpatient care in the left-hand columns, outpatient care in the middle set of columns, and professional services in the right-hand columns. A quick note that the measure of utilization varies based on the type of service, with inpatient days for inpatient and visits for outpatient and professional services. So there's a lot going on in this graph, and the first thing you might notice is the 3-year decline in professional visits, which could potentially be related to difficulties accessing care during the pandemic. However, member out-of-pocket costs decreased at a faster rate than visits due to the waived copay policy, which likely made treatment more affordable for those who were accessing care. While professional visits made up most of the utilization, the highest aggregate out-of-pocket and GIC costs actually came from inpatient care in fiscal year 2021, as waived copays lowered professional out-of-pocket costs and unit costs for inpatient care increased throughout the pandemic. The other main takeaway here is that over half of inpatient and outpatient utilization and out-of-pocket costs occurred out of network. The high proportion of out-of-network spending in the full population underscores some of the patterns that we saw earlier in our households with high out-of-pocket costs. Next slide, please. Let's also take a look at spending and utilization trends for anxiety and mood disorder professional services in the full population. You'll remember that anxiety and mood disorders had the greatest out-of-pocket costs of all the behavioral health diagnosis categories. Over the last 3 plan years, visits for mental health services increased as out-of-network utilization and member out-of-pocket costs decreased. This was in large part due to the waived telehealth copay policy that we discussed earlier and the rapid adoption of telehealth for therapy services. The graphs on the right show how telehealth visits increased from 0% of visits to 79% of visits throughout the pandemic, and how members were protected from cost sharing for those telehealth visits. It's possible that the availability of telehealth services may have also made it easier for members to access services in network as opposed to out of network, since telehealth eliminates the impact of geographic barriers to access. As we see the proportion of out of network visits decreased from 44% in fiscal year 19 to 22% in fiscal year 21. That's in the top left side. Next slide, please. So to review the takeaways from our look at out-of-network utilization, we can see that out-of-network behavioral health treatment is a driver of high out-of-pocket costs. Unfortunately, the lack of in-network provider availability that causes members to seek care out-of-network is a systemic challenge that affects patients both within and outside of the GIC. We plan to address this challenge by working with our health plan partners to align with the EOHHS Behavioral Health Roadmap, which breaks down into the following components. First, integrate the delivery of mental health and addiction treatment so that members who have comorbid mental health and substance use conditions don't have to go to entirely different sites for therapy and medication-assisted treatment. Co-locating these services will reduce the barriers to access for these members. Second, expand the number of behavioral health providers who accept insurance. Behavioral health providers have historically been reimbursed at low levels relative to other healthcare providers. This, combined with the administrative burden of filing claims and documenting medical necessity, as well as the ability of patients with higher incomes to pay for behavioral health services out of pocket, entice many providers to only take private pay patients. EHS is working to align incentives to bring more providers into the insurance system, and our carriers are also working on recruiting more providers to their networks. Third, promote cultural competence in behavioral health providers. It's important that members' backgrounds are respected, understood, and accounted for in treatment. Fourth, expand outpatient evaluation and treatment into primary care and community behavioral health centers. Part of this initiative involves empowering PCPs to treat and manage behavioral health conditions, including substance use disorder, which would lessen the burden on specialty behavioral health providers. Pause here if there are any questions on this section.
I don't see any, Lauren. You can keep going.
Okay. So in this last section, I'd like to return to the topic of pharmacy penalties and take a broader look at prescription drug out-of-pocket costs. Next slide, please. Okay. So here we're looking at the distribution of aggregate prescription drug out-of-pocket costs among high out-of-pocket households with $5,000 to $10,000 in out-of-pocket costs in the top set of bars, and the highest out-of-pocket households with $10,000 or greater in out-of-pocket costs in the bottom set of bars. The color of the bars indicates the type of spending, with copay, coinsurance, and deductibles in purple, product selection penalties in green, and retail refill penalties in blue. We've divided each set of bars by brand status along the left-hand side, including single-source brand drugs, multi-source brand drugs, generic drugs, specialty drugs, and over-the-counter drugs. Looking at the bottom set of bars, we can see that product selection penalties are often incurred when filling multi-source brand drugs. However, we know that this is often where manufacturers are incentivized to offer coupons in order to drive utilization of their drugs for conditions where patients and doctors have other options for prescribing. Anticonvulsant drugs made up 80% of the multi-source brand product selection penalties for the highest out-of-pocket households. Again, we do think it's likely that most, if not all, of the members who incurred product selection penalties accessed manufacturer coupons, but we think this is an important area to continue to monitor given the very high penalty amounts that we're seeing for a small number of households. We can also see that the retail refill penalties in blue were concentrated in single source brand and specialty drugs. This makes sense given that these drugs are typically much more expensive than generic drugs, so the penalty amounts incurred per script are higher for these categories. We do know that all 228,000 of the retail refill penalties for specialty drugs in the bottom set of bars were incurred at VA pharmacies, which means that members were not responsible for paying these penalties. For the $224,000 in single source brand retail refill penalties for the highest out-of-pocket cost households, 2/3 of the penalties incurred were for brand name diabetes drugs, including insulin brands like Humalog and Trulicity. Several of the manufacturers for these brand name drugs do have manufacturer coupons or discounts available. However, we don't have insight into which patients may be using coupons to offset the retail refill penalties.
Hey, Lauren,
Next.
Bobby has a question on this slide.
Sure.
Actually, my question is related to the previous slide, which is regarding sort of expanding the, let's say, maintenance piece of, for prescriptions or for medications that, reduce anxiety and mood disorders. How would, when you said you'd expand evaluation and treatment into primary care, like how is that going to be accomplished? I guess I'm very curious about that because I think many primary care physicians don't want to sort of be involved with mental health aspect. So I'm very curious what the plan is to expand that.
Well, let me take a stab at that one, if I may. I think there are a few potential strategies here. I will say that there are providers who do an excellent job of addressing behavioral health in the outpatient setting by having behavioral health providers work closely with primary care providers. I know the folks at Atrius Health, Harvard Vanguard have been real leaders in this area. So there are a variety of models and ways to involve primary care in treatment of behavioral health conditions. But there's a lot of work to be done there. I will say the community behavioral health centers, as Lauren indicated, that is a particular strategy of the behavioral health roadmap that we expect over time will provide an important expansion of outpatient and urgent treatment for behavioral health. I think there's also one of the takeaways from a few of our engagement meetings with those involved in behavioral health was that there's a role here, potentially expanded role for mental health clinics. These are licensed mental health clinics that may or may not ultimately transition into this community behavioral health model in the roadmap, but they do accept insurance, unlike, as we've heard, a lot of individual practitioners. But the opportunity to add some additional capacity there. So I think none of the solutions here, frankly, Bobby, are particularly easy. But I'm encouraged by the fact that there's work being done on multiple fronts by our colleagues at EOHHS and elsewhere.
Thank you.
All right, so we can move on to the next slide. I've just got a couple of slides left here. So I wanted to present an overview of prescription drug out-of-pocket costs in the full GIC population and briefly explain some of the many factors that influence drug spending. So this graph shows aggregate out-of-pocket costs by the top 20 therapeutic classes for the full GIC membership. Each bar is split by brand status, with generics and over-the-counter drugs in purple, multi-source brand drugs in green, and single-source brand drugs in yellow. When we look at aggregate costs, it's important to separate the effects of utilization from the effects of unit cost. And the top two bars here are a good example of this. So we can see that the therapeutic class with the greatest aggregate out-of-pocket costs was anti-diabetics, and the second greatest total out-of-pocket costs were for anti-hyperlipidemics, which are commonly prescribed to lower cholesterol. Let's start by looking at that second bar for anti-hyperlipidemics. We can see that there was a high proportion of generic drug usage in this category, and that the average out-of-pocket cost and GIC paid per script were relatively low at a total of $28 allowed per script. These drugs were commonly prescribed with a total of 767,000 scripts filled in fiscal year 21. By comparison, the top bar for anti-diabetics only had 412 scripts filled, but the cost per script was much higher than the anti-hyperlipidemics, at a total of $338 allowed per script. The anti-diabetic drugs had a very high percent of single source brand utilization that was correlated with the relatively high cost per script. So we can see that unit cost was the main driver of cost for the top class, anti-diabetics, while the utilization was the main driver of cost for the second class, anti-hyperlipidemics. I won't go through each of these rows in detail, but the purpose of this graph is to highlight what types of drugs are driving GIC member out-of-pocket costs and to point to some of the market factors and clinical factors behind those aggregate costs. Next slide, please. Okay, so to sum up our discussion of prescription drug penalties and out-of-pocket costs, over half of the households that exceeded $10,000 in out-of-pocket costs did so because of incurred product selection and retail refill penalties. While these penalties could be substantial for households with the highest costs, there's a lot of uncertainty as to whether members actually paid these penalties, given the availability of manufacturer coupons and, in a few specific cases, additional VA coverage. Despite this uncertainty, we plan to continue to monitor these prescription drug penalties in future reports, as they're an important part of the story for households with high out-of-pocket costs. Next slide, please. All right. We've hit the appendix, so that was my last slide. I'm happy to take any questions or comments at this point.
Before we do that, let me just say a couple of brief words about this. So first of all, this is a lot to absorb. That goes along with providing a significant amount of detail to you all. So I suspect many of you will want to spend more time with it. And if you have additional questions, we are happy to answer those. So please reach out to us and we can continue this discussion. I think it is important to acknowledge here the slide that indicated that the coverage that the GIC offers is richer than is available in much of the rest of the market. It compares favorably even to our benchmark comparators in the government industry in which we are. And so I think that's important to note. Most of our members do not incur out-of-pocket expenses that even exceed the deductible amount. But there are, a small number who have quite high out-of-pocket expenses that approach or exceed the out-of-pocket max. I think, as Lauren mentioned, for pharmacy, for prescription drugs, I think it's fair to say that a substantial portion of that population has options within their plan that they can avail themselves of with alternative drugs, generic drugs, other brand drugs, but they've made choices to incur out-of-pocket expenses by seeking a brand drug. I think on the behavioral health side, of course, I think the story is a good deal different and reflects the challenges and access to services that we all know about and we've talked about a good deal. I will say on the behavioral health side, this does reflect the shortage of providers in network, shortage of those accepting insurance. There are some strategies that we can employ among those I've mentioned. The neurology drug was sort of interesting to me. And I think it's worth us spending some time to understand that in more detail as we head into the pharmacy procurement and discuss formulary with our carriers. But I think the role of coupons as well on the pharmacy side really very likely overstates the impact on our members. And you can see in some of the graphs that Lauren presented that they represent substantial claims for the Group Insurance Commission. They do protect the member in some respects from those costs, but there are also less expensive alternatives to those drugs that in most cases, in the vast majority of those cases, we would want to drive our members to those less expensive drugs. So the impact of prescription drug coupons, I think, is a real cautionary tale about the role that they play in inflating our claims cost. They're really problematic to a plan's ability to use our tools to drive members towards the greatest value.
Hey, Matt, we've got some here, and want to make sure we get addressed. I think, Jane, you might have been first, and then Toby.
Okay. First of all, I just appreciate very much this out-of-pocket report. Thank you, Lauren, for doing an excellent job. As I was listening closely to you, a couple of thoughts went through my head that I just wanted to share. Sometimes data, as great as it is, I yearn for it to have a more human, that we can humanize it, so we can actually see people, imagine people, because as much as we have reason to be proud of being probably a leader in the market in terms of what we do and how we do it, there's always a question in my mind about where are the real pain points, who are the people who are suffering, and to not just see them as numbers, but to see them as human beings, and to find a way to present that information in a way that might even help us think of other ways that we can help lift that segment of the population up, however small. Because when I think about, small numbers, I still think about who are those human beings, and what is their experience. I have to just say that when I was listening to you, Lauren, right away, you were talking about anticonvulsant drugs, for example, and you just brought into sharp relief a young man in our neighborhood who does some landscaping work, but he has epilepsy, I've learned. And just as that chart, as that data shows, he has had to have a combination of meds, a variety of meds, all of which bear a cost, before apparently docs landed on the right med combo that has helped to minimize the seizures that this wonderful young boy experiences. So that's what I mean about the humanization of data. Sometimes bringing that in front of my mind, it makes me think, what else can we do? And so I just thank you for the report, though. I think it was just excellent.
Thank you so much for the feedback, Commissioner.
Am I up, Valerie?
You're up next.
Lauren, thank you. This is terrific. It's good analysis, and it's very understandable. And my comments, I'm not going to be as eloquent as Jane, but I've seen this report, not as elegant and not as detailed before. I mean, I'm in my second tour, and it's like, this is like a regular thing. Are we going to do anything? I mean, I'm just frustrated, incredibly frustrated. I mean, you've got a population, especially in the behavioral health And I'm roadmaps are things you do in the future, not in the present. And OHS, big bureaucracy. So I just want to know whether they're going to do something, because this is I mean, especially in the behavioral health, it's not only the impact on the individuals, incredible impact on families. I suspect we don't even fully understand the, the costs and the human aspects that, one person that we really don't deal with. Like, I don't know why we have to, every story I've heard is out of network for that. We got a lot of out of network. Who says they have to be out of network? Let's make them in network. Let's go cut a deal with them. I mean, this is crazy. I mean, but it's not your work, Lauren. It's just many years. It's great work, and just keep it up, please. But I just want to know, and I don't expect an answer today, but are we really going to do something? But maybe it's a roadmap, but that doesn't satisfy me. Then that makes a difference. So, thank you. I don't think I have any more to say.
Yeah, thank you for that, Toby. And the frustration you express is one that we share. We look at the challenges that are represented here in the data and the human faces behind them. Thank you, Commissioner Edmonds. And I think that is the appropriate response to what you've just seen, particularly on the behavioral health side. And candidly, as a Commonwealth, we need to keep that urgency high. And I'd say at the GIC, it's we're one piece of the puzzle here. We're an important piece of the puzzle, and we have some tools that we can employ to address these, but it's really going to take a persistent Commonwealth commitment to address this sort of glaring gap. And so I just want to say that your frustration is heard, it's shared, and it's appropriate. And we will be, and we are, and will continue to be working with our colleagues to find ways to be supportive of that broader agenda. I will say the roadmap itself, the roadmap is being implemented. So again, you'll hear more from us about that. But I also want to temper expectations. These, it took decades of candidly neglect of the behavioral health treatment system to create, and it's going to take some time to remedy those things. And I think, Commissioner Edmonds, to your point, I think one of the things that we can contemplate here in future presentations is perhaps some case studies, some specific examples that can, we'll of course de-identify them, but real life, real world examples of how our members have had to handle these issues.
I'm going to say one more thing, then I'm going to shut up. I think if we wait for a Commonwealth response across the board, I think we're going to be sitting here with the same. We're going to be sitting here with the same conversation next year, excuse me. And not that roadmaps shouldn't continue and major structural changes. I think there are some very pinpointed things that we can do as an individual organization, or at least try to do. Maybe we'll get shut down. But maybe it won't be, but it's got to be.
Yeah, and
network. Well, why don't we buy coupons and distribute them to people and things like that? So.
And Toby, you make a good point. There was some data that we looked at. You probably remember, like 2 or 3 years ago, where our health plans were underpaying counselors more than what they were paid.
Yes,
under.
I remember that. Yes.
And
yes.
we quickly, the GIC staff quickly.
I understand.
Right. So there's precedent that we can go out and discuss, rate increases or network definitions. We can do that. So,
Yes.
it's good. It's good sense of urgency. So thank you. All right. This was a great presentation, Lauren. I don't see any other questions unless Bobby, is that a new question?
Yes, it is a new question or a new comment. First, I want to echo what both Jane and Toby said, that Lauren, the report was fantastic. It was very informative, gave us a lot of info, but I will echo what Jane says. As you were presenting that, I'm thinking, who are these people? 71%, if I'm correct in my recollection, of family, it's substance abuse, which we know we read about in the paper every day. Are we talking about, what is that age population? What's the, gender and ethnicity? Like, who are we talking about? And particularly with anxiety and mood disorders, because we know that COVID, the isolation, right, that many people had, increased, right, for people who suffer from depression pre-COVID, right, the situation has been made far worse. And the pandemic has had a huge impact on substance abuse. I know it just anecdotally from what I hear. So who are these people? Who are our members? What's the population? Are we talking about college age? Are we talking about high school, middle school? And how can we focus, right, more directly on those populations? So although I appreciate all the data and I'd like to get more into the weeds so we know, to Toby's point, where we can focus, right? Just like we did with telehealth, which had a huge impact on increasing services to people, even when, we no longer had free, or no copays when we went back to the copays. Telehealth itself was huge. And so we need to do something, because if we wait for the Commonwealth or we wait for the legislators to do something, decades will pass.
Yeah.
So
Comments, Bobby. Anything else that you want to add? Because I did like that they suggested doing more case studies and bringing to life some of these. So that's good. I do think we need to move on in terms of the agenda to end here at 10:30. So if there isn't anything else on the out-of-pocket report, I want to thank Lauren and all of the commissioners for their input. And let's move to the next topic.
Thank you, Madam Chair. At this point, I'll hand it over to Akra Shabeli for a quick update on our engagement activities.
Thanks, Matt. Good morning, Madam Chair, Vice Chair, and Commissioners. I'm pleased to come back to you today with an update on our engagement strategy. And I'll try to go through this pretty quickly. Just as a reminder, we have three main objectives in carrying out our robust engagement strategy. First, we want to make sure that we're clearly communicating our timeline for procurement and our priorities in the development of the procurement so that all stakeholders are aware and informed. Second, through our engagement meetings, we are learning and collecting feedback such that we can inform the drafting of the RFR that will ultimately lead to the procurement. And third, through our engagement process, we're building confidence in the process itself and being responsive to stakeholders, resulting in a successful procurement later this year. So this slide is a non-exhaustive list of the many engagement meetings we've held to date. As you can see, we've been very busy, but these are not the only mechanisms for feedback and engagement that we've utilized thus far. As you recall, we had the member preferences survey this summer. We also completed our annual stewardship meetings and had a teletown hall with mass retirees. Those are just some of the other feedback mechanisms. And as we do annually, we'll host our public information sessions, which are happening next week, as Matt mentioned, where we will also discuss procurement and seek member feedback. We'll have a slide on those session dates, times, and registration process at the end of today's meeting. From these meetings and other feedback mechanisms, the following themes have risen to the surface. These themes are refreshed from an earlier presentation, so I won't read through each. However, I'd like to highlight the notes in the affordability challenge section, which has been the key area of focus for the majority of our meetings. Since our last engagement update in the fall of last year, there have been more recent and pressing insights. As we know, the healthcare delivery system has been under significant pressure since the onset of the pandemic, with additional pressure because of the Omicron variant. This creates obstacles to the development of our strategy because of unpredictability and a desire to minimize any additional pressure on the system. Of course, we need to be mindful of this important context while understanding that we're developing a strategy that will address long-term trends for a 5-year period that doesn't actually begin until 18 months from now. And additionally, one other point I wanted to call attention to, and with no surprise, is that concern continues to build around the cost implications of provider consolidation and high-cost delivery systems. So again, these are, additions to the key themes that we saw on the previous slide, just more recent insights as I think our timeline draws nearer for the procurement and the issuance of the RFR. Just a quick update on engagement, and that's all I've got for you today.
All right, well, I'm glad that engagement is continuing, and we do have a slide you said at the end about the listening session, so that's a key part of your strategy. So we'll look forward to all of the commissioners at least attending one or seeing one on replay. That's great.
Yes. Thank you.
Thank you, Madam Chair. Thank you, Erica. Last agenda item, we will hand it over to Jim Rust to give the CFO update.
Thanks, Matt. Good morning, everyone. I'm going to be relatively brief as well, as we did a fairly deep dive on this last month. So you have the slides in your packets, but I will answer any questions, of course, if you have them. I will pause on this slide, as usual, it gives a little trend on where our medical claims are going, and we're approaching a pre-COVID level. The trend line continues to increase. So this has been the story for quite a while, but obviously new waves of COVID affect this. So it'll be interesting to see with the lag, how this plays out over the next few weeks. Next slide, please. And also, this is our COVID spending. And again, I won't linger on this too long, but as I've mentioned before, you can see over the course since August, over the 2 years, of COVID, that you can see the waves in this, although on a little bit of a delay. And I think we're seeing now the rise up with the Omicron wave in our COVID claims by month as well, along with treatments. I always want to mention that too, because more treatments have come up along the way, and to the extent we're paying for those treatments, you'll also see that reflected here in our COVID claims. So I suspect the next month or two will also show the cost of the Omicron wave coming through to us in claims. Next slide, please. On the next two slides, basically are just our payments by plan. We'd like to show you this so you know where our budget is going, but I won't linger on them very long. This is the state side of those expenses. And the next slide, please, is the employee share of those expenses, which, as you know, are a mirror image of each other. Next slide, please. And again, the next three slides are the usual slides I show you concerning budget and the budget shape and where we are. So you can see we're trending in the right shape, but a little bit under spending where we forecast ourselves to be month by month. Next slide, please. And this is where we expect spending to go in the blue line over the next several months. And next slide, please. And again, as you know, I like this slide because it shows kind of the enormity of our budget. Although we have a bit of a variance, our budget to actual is actually fairly right on top of each other. And the last slide. Here's the numbers behind all those slides. So again, I'm happy to go back and talk about any of them, but we currently show a favorability to budget of about 40 million. And as I mentioned before, some of that is part of a pharmacy rebate credit that came in a little earlier than we expected. So we think we'll work some of that off over the next couple of months because we got that credit a little early. But I would say it's safe to say in terms of regular claims and expenses, we're somewhere in the order of 25 million to the budget if you adjust for that pharmacy rebate. So with that, I'm happy to take any questions. And again, this will always be in your deck and can be reached anytime if you have questions in between meetings as well.
And Jim, do we expect another tranche on the pharmacy rebates? And are we getting the level of rebates from the PBMs that they had promised us in the first year of this 5-year contract? Or are we seeing some sliding of what they've been paying out?
And we're seeing definitely the rebates where we expect them to be. We have a very good contract with the PBMs with some guarantees and whatnot that keeps the rebate levels at least a minimum level of what we expect. And we're seeing them come in there or exceeding that over time. And in that slide where I show the shape of our spending, we've incorporated our expected rebate amounts and timing into that. So most of the time we have that pretty right, but once in a while, due to things out of our control, maybe a federal regulation change or something, the payment date might slide a month or two, but we get them within the same year for sure. So we have a pretty good handle on it, and we expect things to work out as we expect.
Okay, great. All right, good. I don't see any questions. Let's see. No.
Great, thank you all.
Thank you, Jim. Thank you, Madam Chair. This concludes the agenda. Thank you, Erica, bringing up the details about our annual enrollment public information sessions, which we're holding next week. As the chair said, we welcome and encourage commissioners to listen in. They're usually lively sessions. They get more and more lively every year, especially with the virtual format that we've set up.
And so basically for anybody to register, they just go to mass.gov/GIC, like any of the commissioners can do that for these 3 dates.
Correct. There's a banner located at the top of our website that's really easy for folks to find and click on, so you won't have to navigate through the GIC website to find it. It'll be right there at the top as soon as you go to our website, and it'll bring you where you need to go.
Okay, great.
There's also on the website, I just want to plug our website to commissioners and anyone else that's listening. All the steps that we take around COVID, and in particular COVID testing, since that has been a quickly evolving landscape of coverage. We have substantial information up there for our members to understand what's available to them, and we're constantly updating that based on new information that we get.
All right, that's terrific.
See, Commissioner Choate has a question.
Quick question. Can you, on a subsequent meeting, can you somebody update us on either your agenda or your activities or your accomplishments in the My GIC? I mean, you guys did a phenomenal job of rolling that out according to plan and all that type of stuff. And that should be an ongoing effort, you know, to continue digitization of everything we do. And it doesn't have to be the next meeting; it could be the one after. But it's clearly it's a great strength you have, so we ought to leverage it.
Yeah, thank you for that, Commissioner Choate. There is a tremendous amount of work going on, and I think a very good story for us to tell there. And we will be certain to do that at a meeting very soon. It's going along. It's going quite well, I will say.
Thank you.
Thanks. And I will say, with all of the other work that we have going on, it's a tremendous investment of our time and human resources across the organization. So there's a lot to talk about, so we will bring that back.
Awesome. All right. Anything else? Any other comments by commissioners? All right, so next month, as I mentioned at the beginning of the meeting, we will vote on plan design. So this is the last year of our contract. So the next time we do this, it will be with a new and innovative, we're looking for healthcare benefits. So see you all at some of the listening sessions. Anything else? All right.
Nothing from me.
Okay, well, at this point, the meeting is adjourned and we'll see you next week.
Thank you all.
Thank you.
Bye.
Thank you.